Good evening, Dr. Nitin.
Yeah, good evening. How are you?
I'm good, sir.
Okay. So we are starting.
Yeah, we're starting in like 1 or 2 minutes. Dr. Narendra is also joining.
Good evening, Dr. Nitin. I'm Dr.
Hi.
Ratna.
Hi, how are you?
I'm good. I'm good.
Yeah.
Good evening, Dr. Nitin. I'm Ratika Javeri.
Yeah, hi. So, yeah, after my talk, I'll be traveling, but I'll be in the car with the, I'll be logged in.
No problem.
Yeah.
Sir, you will be playing your PPT from your end?
Yeah.
Okay, no problem.
You want me to just share the screen and see? That's okay. That day we tried.
It worked well.
Yeah, it will work. No problems.
Yeah, Dr. Narendra is online.
Good evening, sir.
Hi, good evening, good evening. Hi, sorry, 1 minute late I was.
No problem,
Yeah.
but
Good
I think you
evening,
have the light
doctor.
coming from behind, so we can't see you very
so
clearly.
I have to do something. I'll change the room.
Can we have the background removed? Shall we start?
Ma'am, we are just starting in 2 minutes, just 2 minutes.
And what I can do is start with the introduction, and then you can play the slides. So good evening, everyone,
We're not live, I
and
think.
thank you for joining. Good evening, everyone, and thank you for. We don't want the background, Khushbu. It's not the right background. You can kindly remove this. Good evening, everyone, and thank you for joining us for this session today. This is the culmination of a series of events that happened over the last 1 month. And as you're aware, March is considered the endometriosis month. And we started this journey about a year back. And when we did a sort of a opportunity scan, because we work with several patient groups, we found that there is not much work done around women's health in the context of India, except for, of course, maternal and child health. Whereas when I attended patient conferences in other countries, I found there was a strong movement around endometriosis, PCOS, and other conditions that are related to women's health. So obesity and diabetes, for example, in women, teenage obesity, all those things were being discussed quite openly, but nothing in the context of India. And therefore we decided to start this journey and see whether patients and caregivers and people who had endometriosis were willing to come together to speak about their condition and be open about it. And we conducted a series of focus group discussions, 16 in total, in fact. And these focus group discussions threw fantastic insights. So the women were from across the country, from rural and urban settings, from various regions, and each one had their own unique problem or story to share with us. So what we did was, this was such rich data that we collected that and we composed it into something called patient journey mapping. So we have 3 sets of patient journeys for different stages of women from different experiences. We also came together with this whole idea. In fact, the patients in our group suggested that just discussing amongst ourselves is not enough, and we should go wider and be able to discuss this in a bigger platform. And why don't we do something except having webinars? So we then designed something called the Endo Run, and we planned it for 5 cities, and we already completed it in Delhi and Pune. We are now going to have it over the next week in Hyderabad and Kolkata, and then we'll finally culminate it in Mumbai. The original plan was to have everything within March, but because of school exams and university exams, we had to sort of stagger it a little bit. And the idea was to have this expert session as the finale to those 5 events that we had. But our planning went a little bit awry because of exams. So we are having it sort of in the middle of the events. And I think it's very good because all the people who will join this session today will be able to learn from the experts on what kind of challenges of diagnosis and treatment we have for endometriosis in the context of our country. I have got 5 excellent speakers who have joined us today from different parts of the country, and they will be bringing very unique perspectives about the condition, as well as what kind of challenges are there when, as caregivers and providers, they face the challenge themselves within their homes, as well as healthcare providers and diagnostics, etc., when they are working out of hospital systems and patients come to them. So I've already introduced myself. I'm Dr. Ratna. Our first speaker for the day is Dr. Narendra. Can I have the next slide? Dr. Narendra Malhotra. I cannot see this slide, so let me just read from mine. So Dr. Narendra Malhotra is the Managing Director, Global Rainbow Healthcare, Ujjwala Cygnus Rainbow Hospital. He's also the Director of ART at Rainbow IVF and several director positions. He's a National Director, Ian Donald School of US Ultrasound, Professor of Sarajevo School of Science and Technology, Croatia, Professor in International University, Croatia, past Vice President in several societies. And he's also the founder editor of a journal and the member of the FIGO Guidelines Committee. FIGO is the International Committee for Obstetricians and Gynecologists, not a committee, a society. And he's also the chairman of Smriti, an NGO which looks at new level of care. The speaker who follows him is Dr. Nitin Chaubal, and he again comes with several accolades to his name. His present attachments are he's a consultant in ultrasound, Jaslok Hospital and Research Center, Mumbai, and he's the director, Thane Ultrasound Center, Thane, and a professor emeritus at D.Y. Patil University, Navi Mumbai. He has immense teaching experience as a visiting faculty at St. G.S. Medical College and is presently a teacher for postgraduate radiology students. And he has conducted innumerable workshops in ultrasound and color Doppler. Following him, we have a speaker, Dr. Meenakshi Ahuja, who recently was there with us in one of our events in New Delhi for the Endo Run. She's a gynecologist and obstetrician at Fortis La Femme and has several years of more than 2+ decades of experience. She's well known by her patients as a competent and compassionate doctor, and we saw this in person when she was addressing students at IHMR New Delhi. She's chaired several sessions in various gynecological forums and has an impeccable reputation and is well renowned in local and international circuits. And she's been practicing obstetrics and gynecology in private hospitals and nursing homes in South Delhi, including Fortis, Mass, Spring Meadows, and Modi hospitals. We have a very distinguished speaker following Dr. Meenakshi, and he's Peter Said. He's a registered nurse and an MPH and head of patient engagement APAC at Bayer Pharmaceuticals, and he will be speaking to us through a recorded message. And our most important speaker of the day is Dr. Radhika Javeri. She is an endometriosis patient and patient advocate, and also a holistic nutritionist, women's health coach, founder of Pain Free Endo System. She has addressed several of our patients in our expert sessions. She is internationally certified endometriosis coach and endo warrior since the age of 13 and helps endo warriors to live pain-free by managing their symptoms with a holistic approach. She believes in adding menstrual hygiene and hygiene for girls in education system and loves reading, dancing, and traveling the world. So welcome to all the panelists. It's a great pleasure to have you with us today. And we will start with our first panelist, who is Dr. Narendra Malhotra, to be speaking to us about his topic for today. So over to you, Dr. Malhotra.
A very good evening to all of you. It's indeed a great pleasure to be here on and addressing all of you on a topic which is very, very dear to us here. And just a second, I can't get this screen. Endometriosis. And endometriosis is something which it's a very debilitating disease and a debilitating disease. So what has changed was something which I'm going to talk about, and some gold standards for treatment and current options in India, including some financial support groups. And me and my wife, Dr. Jaideep, who is a co-director with me, bring you these presentations. So endometriosis is an enigma. It's a very complex and elusive and challenging disease. I call it benign cancer because it is cancer and it is not, it is benign, but it is not cancer, but it spreads. And as the month of March, we all experts are trying to share what this disease and how it affects women. So women face with endometriosis, come to us with infertility, chronic pelvic pain, nausea, abdominal bloating, fatigue, depression, anxiety, among others, many other common symptoms associated with our disease. Let's see how this endometriosis places high burden on the society. So the high burden is placed by individual impact, by delay in diagnosis, and by societal impact. And that is because there is an increased risk when the girls have early puberty. Dysmenorrhea and pain causes loss of hours, and dyspareunia, comorbidities, dysmenorrhea, fitness, infertility problems. Then majorly it affects or impacts on the sexual life and on the academic professional performances and the impact on personal relationships. And the healthcare cost, utilization, unemployment, abstinence, negative impact on goal attainment, reduced work productivity is all a societal impact. So when we look at all these, severity of the symptoms, some people say we don't know how severe it is. Some people are not affected, mildly affected about 16%, mainly sexual life, moderately affected about 26%, and severely negatively affected are about 25%. And this is sexual life, relationships, housekeeping, all the activities which I just told you. So it is a disease which is not only a medical disease, it has a social impact also. So the negative impact also is seen on ovarian reserve. When we have big endometriomas, ovarian endometriosis, the ovarian reserve goes down and infertility comes to them early in life, and if not handled. When we look at this article, it says endometriosis is a chronic gynecological condition which has been referred to as a missed disease. No, we are not, because people were not clear, and even healthcare providers and doctors are not clear about it. And it has been largely ignored by the government policy in research funding, despite of having such a major impact on the society and on the work. So what happens is that to explain pain, we have to provide validation, to reduce the feelings of isolation, and then to provide an early treatment so that to impact the natural history, so to reduce the chronic pain, reduce the pain syndromes, and reduce the risk of infertility. So we need to go step by step like this. And what people don't let go step by step is that women wait for almost 3 years before they start seeking medical attention for pelvic pain. And then the physician has a knowledge gap. And there's a physician resistant to learn about any pain in abdomen is intestinal, appendicitis, chronic PID, pelvic congestion syndrome. So those vague terms are given to this disease. And of course, when it comes in adolescent, it is a patient knowledge gap and the patient normalization. So the frequent misdiagnosis is chronic pelvic pain, bleeding disorder, irritable bowel or colon, food intolerance, psychosexual complaints, overactive bladder, PID, appendicitis. And see, in this circle, nobody is thinking of endometriosis. That is what we got to change the attitude of think endometriosis. So the delayed referral from a GP to a gynec consultation takes about 3 years. 30% have had more than 6 primary care treatments before they come to a diagnosis. 49% have had more than 2 secondary level referrals. 2 gynecologists seen them, and then they come to a diagnosis. And most of them have been given 3 different types of COCs, and the pain is still persisting. So the interventions to reduce the diagnostic delay, we have to improve knowledge. We have to stress on faster referral to gynecs. We have to improve the quality of physical examination. Patient have to give time. So we need to have chronic pelvic pain clinics or endometriosis clinics. And it needs a multidisciplinary team. We all know that. And you have to reduce the waiting list for an ultrasound, for an MRI. In an NI scheme, it probably takes months before they get an appointment for that. We have to improve the knowledge of the menstrual physiology, pathology, and endometriosis to the GPs and even to the specialist. And of course, for fertility, they have to be an early referral to the infertility specialist. So the protocol for early diagnosis would be if the patient comes with pain, gynecological symptoms, non-gynecological symptoms, or adolescent not responding to NSAIDs. And if the answer to all these is yes, then they need to have a pelvic exam, either PV or rectal if they don't allow that. And if there is a painful nodule in the tenderness, you start suspecting deep endometriosis. If there is a visible vaginal lesion nodule, start suspecting. If there is an adnexal mass, endometriomas. Or if there is a uterine enlargement, adenomyosis. So clinical diagnosis will be made on a thorough clinical examination, and then they go for imaging, which will be discussed. So history, physical examination, clinical diagnosis, or suspected diagnosis, then imaging, and then we start thinking of any interventional procedures like laparoscopy and all. So why endometriosis specific imaging is important? Because we want to diagnose it, we want to map the disease, we want to assess the severity, and we have to provide a triage of care. So this will be discussed. Now, there are many classifications which were made: mild, moderate, severe endometriosis. Then came the American Society Reproductive Classification, but these are all complex. Then came the NZN classification, and then, of course, we had the IDEA group giving us a AMOS classification. AMOS means adenomyosis, EMOS means endometriosis. So for here, you had to go stepwise. 4 steps: evaluate the uterus adnexa, evaluate transvaginally by soft markers, do the sliding sign by ultrasound, and then assess the deep endometriotic nodules in the anterior and posterior compartments and give them a score. And you see, this was simpler, and all gynecologists who are well versed with ultrasound, or not even well versed, average with transvaginal pelvic ultrasound, can do this. And that has to be taught to all of them. Then, of course, for fertility, we need to do fertility prediction. So we have Adamson's score, and again, a very simple score, 10-point assessment. Only 2 points are directly related to endometriosis. The others, and if EFI is not a classification of endometriosis. It will just predict that what they need for fertility treatment, whether they need to wait, whether they need ovulation induction, whether they need IUI, or whether they need to go straight away for IVF. So that is it. Then what is important is that we want to have valid guidelines. And these valid guidelines, if they are there, should be circulated well. So we had valid guidelines by ESHRE. ESHRE endometriosis guidelines is very, very good guidelines. And 2012, 2014, and now we have the comprehensive new ESHRE guidelines of 2022 with 109 recommendations on diagnosis, treatment, and all. And this should be simplified document, should be circulated to all the gynecologists, especially in the 2nd and the 2-tier and the 3-tier cities where they are not so academically going to conferences. So there have been some changes in the guidelines. The first change was that you don't need laparoscopy as a gold standard. And chapter-wise, all these changes occur. So laparoscopy is no longer a diagnostic gold standard. You can diagnose by ultrasound and not need diagnosis. Then you can diagnose by clinical symptoms, which is the first step: dysmenorrhea, dyspareunia, dysuria, dyspepsia, painful rectal bleeding, hematuria, shoulder pain, pneumothorax. All these should give you an indication there's endometriosis. And then make a diagnostic algorithm. So go follow the diagnostic algorithm given by the guidelines. We can discuss this later. Depending on that, you classify the patient. She is adolescent, she's in reproductive age group, she's in perimenopausal age. If she's in reproductive age group, whether she wants fertility or not fertility. If she's having infertility, so the treatment. And whether her treatment complaint is pain or infertility or the others. So we will start the treatment with analgesics, we'll start the treatment with combined OCPs, we'll start the treatment with only progesterone, GnRH antagonist, agonist, aromatase inhibitors, and if still not relieved, or if it's a big lesion, then surgical treatment. So surgical treatment is not the first line again, and it is recommended to offer surgery as one of the options to reduce endometriosis-associated pain and infertility. So surgery, what we used to do when we were taught in 2012, that do surgery first. Of course, if you have endometriomas this big on ultrasound, and she's infertile, or she's having severe pain, she will have severe pain. This needs to be surgically done. Complete surgical treatment is hysterectomy for perimenopausal or menopausal women. But sometimes even that, the pain recurs because it's in the peritoneum, or it's in the bowel, or it's in extraperitoneum. So there is a strong recommendation to add medical therapy as adjuvant to surgery. There is a moderate recommendation to add comparing the medical and surgical treatments, and to do some non-medical management strategies, psychologically, Chinese medicine, acupuncture, acupressure, nutrition, yoga, electrotherapy, physiotherapy. All that can be added to increase the general well-being of the patient. So if the complaint is pain, painkillers, hormone, surgery. That's how we go. If it is infertility and the tubes are patent and the sliding sign is negative and there are no mass lesions, adnexal lesion, medical assisted reproduction, mild ovulation induction with IUI. And if there are grade 3 or grade 4 endometriosis, then we'll do the EFI or the prediction Adamson score, and depending on that, take them for IVF or ART. If there is mild dot-like lesions here, the new guidelines say that you need not treat them. But supposing you're doing a laparoscopy for unexplained infertility and you run into them, then we tend to fulgurate them so that they don't grow into bigger lesions. Of course, if there are lesions like this, which are big bilateral endometrioma, kissing ovaries with an omentum stuck in between them, then depending on the pain and the age and previous surgeries, we go ahead and manage them surgically or non-surgically. Now, if this patient has had 2-3 surgeries and this has recurred, then there is a place for just drainage and stimulating them, collecting as many oocytes as possible. So oocyte pooling and then doing IVF or ART. So ART can be performed for infertility associated endometriosis, especially when it is